Welcome to Take Control of Your Image Data webinar. My name is Leslie, and I'll be your operator for today. At this time, all participants are in a listen-only mode. Later, we will conduct a question-answer session. Please note that this conference is being recorded. I'd now like to turn the call over to Ms. Robin Della Penna. Ms. Della Penna, you may begin.
Thank you. It is my privilege to welcome you all to our VNA webinar, and I would like to take a couple of minutes just to bring you up to speed on what's happening at Key Information Systems. Key Information Systems was founded in 1999 by Leif Morin. We're a premier and a specialty elite business partner. This is the highest level of achievement we can obtain with IBM, and we've held this position for 13 years running. We have demonstration centers in the West, in Woodland Hills and Irvine, where we run workshops, explore manufacturers' product sets with hands-on capabilities for our clients. We have servers, storage, SAN, and software physically on site for many manufacturers. We participate in beta programs, and we have excellent training and engineering training to meet client requirements. We have 55 employees as well. Our mission statement is to become the leading provider of information technology solutions in the Western United States and find growth through excellent client service, strong technical experience, and devotion to personal success. Why partner with us? We have client execs with 15 to 20-year client relationships. We work closely with our manufacturers, IBM, NetApp, VMware, Brocade, Cisco, just to name a few. We have over 150 manufacturer certifications, a deep technical bench. We've made an investment in a CTO who guides our technology recommendations internally and with our clients. We know when problems come up, how to work quickly with the manufacturers, pinpoint the problems, establish an escalation path, and resolve for our clients. And all of our thoughts from our CEO on down in every decision we make are how can we add value to our clients? What we do, well, we do enterprise architecture. We discover, which means getting a clear direction of your business objectives. We design networks, systems, storage, virtualization, management and protection infrastructures and processes. We implement, partnering to your schedule, preparing, deploying solutions with minimal disruption to your IT operations. In other words, knowing your environment when we get on site. We manage by providing retainer services, monitoring services for specific solutions, and we support through our manufacturers contract and maintenance services. My last slide is to articulate and just to give you a view into the solutions that we build. What's most important that I leave you with is that we have highly trained engineers and a sales team with long-term experience in core technologies. We know how to do hardware, software, and services to form solutions that are right for your business. Please let me know how we can help. Thank you for your time, and I hope that you'll find our webinar to be of value. I would now like to turn it over to our presenter, John Shoemaker. Thank you, John.
Thank you. How's everyone doing today? I want to walk through, just a very high-level VNA, what to look for, how to define your need, and kind of the clinical attachment with the VNA. It's more than just a storage platform. There's a lot of interoperability that goes on within a VNA. So a little bit about myself. I've been around in the clinical technical world for about 19 years. I've lived many different lives within this time frame, from the technical side all the way over onto the clinical side. I've done very large implementations all the way down to single imaging centers. I'm published in several magazines, and I have links at the end of the slide to if anyone would like the articles, they can request them. So the current environment, why are VNAs becoming such a loud voice in the marketplace? A lot of the clients are experiencing a lot of issues with interoperability between systems. They're in acquisition mode. They're acquiring new imaging centers, hospitals that have existing technology, and it doesn't make sense to deploy their enterprise standard to these systems because in many instances the ROI hasn't been recognized on the systems that exist at those facilities. But also within the enterprise, when people used to speak about PACS or imaging, they always thought about radiology. And unfortunately, imaging exists in a lot of different verticals within the enterprise outside of radiology. And unfortunately, applying the PACS workflow to those different ologies doesn't simply work because they don't use DICOM. The workflow doesn't work for them in those departments. A prime example of this is cardiology. You cannot apply radiology workflow to cardiology unless you want to be chased out of the hospital with a crowd chasing after you. So the current environments, you have silos. A lot of the systems that are deployed at the departmental level typically are not interfaced. So all the data is manually entered. It's dirty. It doesn't conform to many of the standards. There's no standard deployment typically throughout the enterprise. Sometimes when the hospital IT department goes in there, if the lights are flashing and you can log in, it's good. There isn't typically a solid deployment methodology that's employed throughout the enterprise. If the departments own it, then implement, then typically they don't adhere to the IT standards. So there's different storage platforms. I've seen RAID devices laying on the counter in the break room underneath the coffee pot. The departments, they have a clinical need, and if they don't get that from IT, they're going to move forward and they're going to obtain that clinical solution. And IT is an afterthought to the clinicians when they're deploying systems. So they will figure out a way to get the tools that they need to do it with or without IT at that point. So with that, because the departments haven't deployed systems, they don't have the experience of deploying systematic, logical data processes throughout their implementations. You end up with a lot of dirty data. You have non-redundant storage. If you go over to pathology and you mention replication, clustering, system architecture, they'll look at you with glazed eyes. You have multiple applications throughout the enterprise, and typically, in cardiology is another prime example of this. You can easily have 4 different systems that the cardiologists are utilizing to treat a patient, and there's absolutely no interoperability between all 4 of these systems. So the cardiologist has to go and walk around to 4 different workstations or 4 different areas of the hospital just to try to bring together the patient record, just so that they can make a diagnosis and treat the patient. You also, with the interoperability, a lot of these smaller imaging systems, they don't have APIs or any method to integrate at a desktop level or application level, with other systems. I've seen many of them, they don't even conform to the DICOM standard, which then brings in the whole non-DICOM issue. Let alone passing patient information within context between multiple applications. And typically when it's implemented within at the department level where IT is not involved, there's really no direction or vision. The clinical departments, they have a need, they find a solution, they're not thinking 5 years down the road. They want the fix now, instant gratification, and it's typically later on down the road where now they want this data to be absorbed up into the EMR or shared with other departments or referring physicians, and it's not easily possible without a lot of heavy massaging. So the different business verticals, we all pretty much know that imaging takes place in radiology, cardiology, but also, takes place in the ER. They're doing trauma fast scans, pulmonology, hematology, endocrinology, pathology is a huge one. And some of these, departments could just be taking pictures of JPEGs, it could be PDFs, it could be WAV files, it could be a multitude of different file types outside of DICOM. In the old methodology is to go in and wrap the non-DICOM file formats. The problem comes into if that clinical archiving system ever needs that data back and you've already wrapped it in DICOM and the archiving system is not DICOM compliant, you can't get that data back without a manual process. So this is just, this slide is an example from one of our clients. They first implemented PACS back in 1995. Everything was good. The problem with PACS is inherently, and the vendors have been very slow to respond to this, is it stores everything forever. And back in 1995, when volumes and CT slices and digital mammo really didn't exist, it was very, very small. I mean, most large institutions were growing at about 5 to 7 terabytes a year, and that was manageable. Unfortunately, as imaging became more technically advanced, the study sizes started to explode, different acquisitions, migrations. There's an albatross of storage devices in a lot of these IT data centers. And, within 8 years of a client that's looking at 1.8 or 1.2 petabytes of image data, and that's just radiology. That's not even approaching cardiology, pathology, and the other imaging systems within the enterprise. And unfortunately with this, if the PACS application ceases to meet the clinical need and they're looking at having to replace that PACS system, a migration of this magnitude, you're looking at almost a $2.5 million migration, and you'll also have to buy new storage in order to migrate all that data into just to use a new clinical application. There's huge impact on timeline, on the implementation path of that clinical system. So there is a large data problem within the marketplace at this point, and that's where the VNAs come in. To when you migrate into a VNA, now you can replace that clinical archiving system of PACS, cardio PACS, pathology, whichever, at a faster rate, because now you're no longer having to do the migration because the images and the reports reside in the VNA, and you simply build your dictionaries of the clinical system and you create a routing rule, or you do a quick one-time rapid migration. But basically your migration costs are almost eliminated. Now I say almost eliminated simply because if you ever replace your VNA, you're going to have to migrate the data. So some of the VNA requirements, a lot of the facilities, they have an enterprise storage methodology or strategy. If they do, that's great. The VNA architecture or VNA system should be able to plug right into that enterprise storage, so the health system can recognize additional cost savings. There's no reason why a VNA vendor should say you shall use X storage system because that's the only one that we integrate to. And sorry if you have NetApp or EMC or IBM, we only use Hitachi or whatever. The VNA system should be able to utilize multiple different types of storage platforms. Also, you have to be able to intelligently integrate into the information system. So this is not just a DICOM repository or an object repository. The thing that differentiates VNAs from archives is the VNAs keep the object up to date with the enterprise. So if you are removing a clinical system and you migrate that data back in, the data is current, not statically held from when it was acquired. You also have to be able to provide ILM to the data objects, or image lifecycle management. Now, this can be from moving the object from Tier 1 to Tier 2 if that's what the architecture is, or if you compress after a period of time, say after 4 years, you can compress it to a lossy image, or if you're dealing with DICOM, or you can actually purge the data, which the PAC systems at this point, very few can even do that. It also reduces the need for image migrations because now you have separated out the long-term archive from the clinical system. But like I said before, if you replace the VNA, then you're still going to have to migrate. Also, the ability to manage DICOM and non-DICOM. Now, the people that grew up in the imaging space, radiology, cardiology, we're very used to DICOM. And for anyone not using DICOM, we sit back and we scratch our heads. Unfortunately, outside of radiology and cardiology, it is the Wild West. And how they acquire the images, the formats that they store the images in, and how they store the images is dependent on the system itself. And the non-DICOM really muddies the water. And until these other systems adopt to standards, this is kind of the pain point that we all have to live with and figure out a solution on how to manage it. And the VNAs have done a great job at providing solutions for non-DICOM data acquisitions or aggregation. The VNA needs to be able to work with a third-party univiewer. So, the whole term, tying your EMR to your radiology packs and then having a separate integration, a separate viewer for your cardiology packs, and then having a separate, viewer or integration into pathology or echo or any of the other imaging departments, a univiewer will hang off of the Vendor Neutral Archive, and with all the different clinical imaging systems storing and utilizing the VNA, it makes perfect sense to view the data that has been updated with the enterprise directly from the archive. Now, it's a read-only view, but what it does for the referring physicians is it unifies the patient's imaging jacket, independent of which system or department has acquired those images. And so the referring physicians now start to get a more complete view of the patient record. Also, the ability to provide the facility the migration tools. Some facilities have very robust IT departments, and they easily can manage the image migrations. And most vendors want to sell you the professional services to do the image migrations. If the IT department at the hospital has the talent and the ability to manage their own migrations, they should be able to. There's no reason why they shouldn't be able to use the internal resources that they have and they employ in order to do the migrations and recognize the cost savings of that. Now, if they don't have the staff on hand, then the VNA vendor can assist with professional services in providing migration services at different levels and kind of help augment that. But it should always be a migration tool accessible by the facility. Also, the ability to securely segment the data for clinical and non-clinical use. Most sites will have research development, or they have a doctor that's utilizing not clinical data, but they're acquiring and doing different studies, and you don't want to muddy the waters with that, but you should be able to still store and archive that for the research purposes, but have the ability to pull that back. Now, some of the VNA constraints, we want to talk about the perfect world of VNA and everything else, but at the end of the day, the VNAs are at the mercy of the clinical archiving systems. If the clinical archiving systems do not follow standards or standard file formats and they create their own proprietary object, the object is still proprietary. There's only so much that we can ask the VNA vendors to do, and when you run across systems like that, you simply mark them as higher priority to replace, and you hope that you can migrate that proprietary data into a more standard format to tie into the enterprise. Also, when you get outside of radiology, cardiology, the use of modality work lists or a patient work list starts to go down, and you have manual entry, and sometimes they're not even they're using their own department level numbers. They're not using the medical record number or the EMPI, and you have to require the clinical archiving systems to have the adequate file header information so that the object can be linked up with the master record. Then for the DICOM people, you still have vendors that are heavily utilizing proprietary fields in the DICOM header, and then you also have some of the clinical archiving systems that aren't even compliant with HL7, so they can't even receive an ADT feed. They would rather have a SQL view of a data store located somewhere within the enterprise, which it makes it very difficult to keep everything in sync. So one of the things that I went through in looking at the VNA marketplace is there's, in my mind, there's 3 different types of VNAs, and unfortunately there's a lot of vendors that are painting their DICOM archives as VNAs, and that's not necessarily a bad thing. It's just as you are looking at VNAs, you need to understand what type of VNA is out there and who offers the VNA that you need. So not everyone needs to drive a Ferrari, but most people need to have a car. And the VNA dissemination is pretty much the same. So the full VNAs, they have web services to be able to publish, the header information and the database to other systems, if so desired. They virtualize. At this point, most systems should be able to virtualize. If they haven't, then depending on your strategic goals, that can weigh plus or minus for the system. Also, there needs to be image lifecycle management, routing, prefetch rules, because if you have multiple PAC systems from 2 different vendors, you're going to have to play with the routing and prefetch rules based off of both of those. You have to have data normalization, because how DICOM comes in from vendor A may not be how vendor B would like to see it. You may need to do some tag morphing within transit between the 2. Native DICOM and non-DICOM object archival in its native format. And I say that because if the clinical system ever needs that data back, it needs to be returned in its native format. If you wrap everything and the clinical archiving system isn't DICOM compliant, it's going to be a manual process to get that object back, and that impedes the clinical workflow of that department. You also have to be able to generate a single patient record across all the disciplines. Full VNA will also give you a single point of integration for image enablement for all the clinical archiving systems. So whether you're tying into 1 or 2 EMRs, it's a single point, and it's a single viewer that can be launched in order to unify and also give the same look and feel to the referring physicians as they're going through the EMR and going through their documentation process. You also have a viewer that should be able to unify both DICOM and non-DICOM objects. Now, viewers will do this differently. There's a plethora of viewers out there, depending on what your needs are and how you are utilizing a VNA, should also lead into the discussion of how do you want to view the data out of the VNA. If you're only using a VNA for DICOM or complex DICOM integration, then a DICOM viewer may meet your needs. Obviously, the VNA should be able to support best of breed. They should have an API toolkit so that, independent of VNA, the viewer should be able to tie in using Wado, Mint, or other web service accesses to the objects. Hybrid VNA, these guys are kind of in the middle. They offer the core infrastructure of a true VNA or a full VNA, but it doesn't typically doesn't include a embedded viewer, and they don't have some of the robustness that a full VNA does. but they still have the web services to publish. They still virtualize. They still exist within ILM. They have routing prefetch rules, normalization. They can store native DICOM and non-DICOM objects. Whether you can access the non-DICOM objects, it depends on the system, the solution, and the architecture of how that VNA is constructed. But you do get a single patient record across all the disciplines, and they do typically tie in with DICOM WADO and Mint implementations for some of the univiewers. Now, the PACS Neutral Archives, there's vendors out there that are rebranding their entire PACS as a VNA, and this is where the marketplace, the waters are very muddied, and it's very confusing for the clients because they go out and they're looking for a VNA, and they have a vendor saying, "Oh, we have a VNA." Really, they're just reselling their PACS system. But PNAs only archive DICOM data. They rely on wrapping or encapsulation. They only utilize DICOM viewers. Some do have some great normalization tools. They may have interface capabilities to keep the data up to date, for ADT from the enterprise or driven from the RIS or the CVIS, so that any merges or patient updates filter down to the object level. And most are utilized for multi-PACS environments. So, they do have robust routing rules, which, still exist within very complex environments. A single community hospital may not utilize the routing rules, such as the university hospital or a large IDN. And they may or may not be able to retain the ability to provide a study content notification. So some of the PNAs cannot notify through HL7 or any other mechanism to the EMR that, hey, there's an image that exists. And that typically is what drives some of the EMR workflow for the imaging. So the next slide is kind of a depiction of the current silos. And, in each of the storage devices could be different. They could be on the same. They could be attached to a NAS, CAS, SAN. Some could still be archiving to MOD or VCR for that matter. But there's typically very little integration interoperability. Within the enterprise, typically the only integration interoperability is going to be between cardiology and radiology because those are the most advanced imaging systems that have had to play in this space for a longer period of time than other departments. So once we lay VNA over the enterprise, our enterprise changes. And on the left, we see the VNA application services layer. We see the DICOM services, web services, the XML audit, depending on how the VNA does the auditing, logging, and also the file system storage. Now, whether you decide to tier or go to a single platform or do off-site, in this example, level 1 could be your SAN infrastructure, level 2 could be NAS, level 3 could be a CAS, tape, or a cloud-hosted solution. Many of the VNAs will be able to utilize a cloud-hosted solution as an off-site DR copy, while the internal local VNA services layer will manage the integration and interoperability between the different clinical systems, driving the required informatics between the systems. And then you have a single point of integration up into the EMR portal, and that EMR portal will be able to launch the Univiewer. And some Univiewers also have the ability to also secondary launch the clinical web viewer for the physicians that after they review the image, that's great, but maybe the pulmonologist wants to take a look at and manipulate the clinical object with the clinical application. And so that'll launch them into the actual clinical application to make modifications. The main goal here is that all the modifications to the object need to take place in the clinical archiving system. Otherwise, you get disparity between the objects if the clinical system doesn't update the archive. So the main thing is define your need. You can't go onto a car sales lot knowing that you need a car. You need to know what type of car, how many people it needs to fit. Do you need to tow anything? Do you need, what size engine? How fast do you want to go? What's your fuel economy? Going in and buying a VNA is much the same thing. It needs to fit. What is your strategic roadmap? Where are you going in the next 5-10 years? Your VNA vendor is going to be with you longer than your PACS or your cardiology vendor typically. And also, what's your storage roadmap? Obviously storage is changing rapidly. Many of us can't articulate what storage is going to look like in the next 10 years. We can make assumptions and presumptions, but how is your storage roadmap, going to work with the VNA? And this is where you as a client takes ownership of how you wish to store and manage this data, not rely on your PACS vendor to tell you how you're going to do it and why you're going to do it, because that's all that they support. Also, how should your enterprise obtain the object access? Do you only wish to utilize the archive as an archive, or do you wish to kind of tie that in more for a clinical representation? What's your plan for health information exchange or regional health organization? Are you going to join that? Are you becoming a member within an ACO? Those items have drastic impacts on how you move and manage your data. Your PAC systems typically cannot tie into those systems because they're very rigid and stringent on how they insert data into their systems. They have to have a radiology order and there's specific workflow. So typically you have to reverse engineer the workflow from the VNA up in order to tie into some of these things. Also, what are your legacy dependencies? Do you have space constraints within your data center? Do you have a large investment into a SAN infrastructure? And you have to be able to sit back and say, where are you now and where are you going to be in 10 years? And, once you've defined some of your basic needs, you'll kind of know what type of VNA you need to go out and get. Now, everyone has been talking about meaningful use. It's been around. The main thing that VNAs do is, in phase 2 of meaningful use, you're going to have to start publishing this data and making it easier to share. And the main thing here is that a VNA assists in doing is it allows you to be able to share and interoperate with different agencies without impacting your clinical department workflow. Instead of having a team of FTEs in the file rooms or in health records managing, pushing, burning CDs, mailing everything, your VNA can integrate into different systems, and you have a single point of integration versus having to buy an adapter for each clinical archiving system and having a unique configuration for each system, which just becomes maddening from a support perspective. But also, if the UniViewer is utilized, you can point one of the exchanges into your UniViewer because you've published all the information up. They can just launch your UniViewer off from your VNA. So publication of the database, to me this is extremely important because as you move outside of some of the HISs and the RISs and everything else, HL7 is a great standard, but for simple publication, you need to be able to easily tie that the VNA database out into any web services, SOA, XML, or HL7. You need to have a plethora of tools under your belt because the integration is not going to be standard. And I've seen SOA start to really gain a lot of movement within the healthcare enterprise, where the larger IDNs are building applications or service buses, and they need applications to tie into that. Unfortunately, many RISs and PACs and imaging systems, they have to re-architect their solutions in order to implement many of the SOA layers. Also used for EMR integration, exchange, and registry. Sending image links or being able to integrate the UniViewer into other clinical systems. For instance, does it make sense to move all DICOM data into the radiology PACS, or does it just make sense to build an integration at the application level so that the PACS can launch the UniViewer and the radiologist at that point can get the unified jacket? So with that, if you have any questions about VNA, Ascendian does offer analysis services. We also do implementation services as well to help guide you down this path. If you have any questions, please don't hesitate to reach out to me. And I've also listed a couple of the articles that have been published. If you'd like a copy of those, please shoot me an email. And with that, I'll turn it over to Leslie to open up the Q&A session.
Thank you. We'll now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you're using a speakerphone, you may need to pick up the handset before pressing the numbers. So once again, if you have a question, please press star, then 1 on your touch-tone phone.
Great. Thanks, Leslie. While we're waiting for those questions to queue up, we had a few questions that came through during the presentation, and one of them is, how scalable is your system?
Hi, yes, this is Nathan Gergel. I'll answer that. As a key partner, Terramedica offers a VNA, key partner with Ascendian and Key Info. Our VNA is very, very scalable, and that's scalable both on the storage and on the volume side. So what our solution can do is basically it utilizes a number of servers that can be from a community hospital, which is doing a 100,000, 200,000 imaging study that is primarily radiology-based, and scale up to IDN-level enterprises that cross over multiple hospitals, multiple clinics that are doing, multiple clinical imaging sources, such as we had talked about earlier, radiology, cardiology, ophthalmology, and that's simply done by adding in the required number of servers needed to scale that out. So that system can grow with you as your enterprising solution grows, and then storage on the back end, again, in a truly full-fledged VNA system, the storage, again, should be able to handle what your enterprise storage strategy is. So you can start out with storage on high-speed cache and then move that out as the data ages to slower speed storage, cloud storage, et cetera, and be able to scale that storage to grow along with the growth of your imaging data.
One of the things that I can add, this is Del Sofo also with Terramedica, is that on a specific case, for example, on the large side of the scale, there was actually a press release yesterday where Terramedica announced that we're the VNA solution for New South Wales in Australia, which is the largest state in Australia. And there we'll be connecting over 110 clinical facilities and cover 9 PACS systems and about 3 million annual imaging procedures. So that kind of represents the higher end of that scale.
Great. Thank you, gentlemen. Leslie, any questions from the audience?
I show no audio questions.
Okay, great. We have a few more that came in. Next question we have for the team is, how truly neutral is your VNA?
Hi, this is Nathan again. Again, that's a very good point for a true full-fledged VNA to be neutral. And the reason for that is so that you can work with your vendors of choice in all areas of your deployment. So that not only takes into account your imaging vendors and systems, such as who's your PACS system for radiology, who's your PACS system for cardiology. The VNA should be able to interface with any and all, and as DICOM has really developed as a standard over the past 10 years or so, that has become less of an issue. But some of your images that you may be archiving may date back to the early days of the DICOM standard, where things may not have been as standard as people would have liked. And so some of that interoperability, challenges may be there to get those images stored and normalized. So you want a system that has the ability to reach out to those other systems that may have that kind of dirty or non-standard data and be able to take that in and to talk between multiple PACS systems, again, whether they're cardiology or radiology or even non-DICOM, so your different other clinical systems. In addition, we feel this also should extend to your hardware and to your storage as well, as we talked about earlier, so that you can use whatever best of breed you want to do and leverage your current strategies, and that's an important point, to be able to remain flexible. As Jonathan had mentioned, this is a long-term relationship you're entering into, and we don't feel you should be locked into any one particular technology choice that you make now. You should be flexible to be able to change that in 5 or 10 years as emerging technology presents itself, and you want to take advantage of that.
Great, thanks, Nathan. And speaking of DICOM, a question came through. What do you see as the advantages over storing non-DICOM data in its native format versus wrapping in DICOM?
Yeah, there's pros and cons to both of those solutions. Jonathan had talked about some of the pros of doing it in the native non-DICOM format, and a couple of those are one is so that you can deliver the image back to your source system for manipulation or for viewing later on. If you do the DICOM wrapping, there are some challenges with that, in that you are required to use a DICOM viewer then to view that source. And with the proliferation of UniViewers, and as we had talked about, UniViewers should be a part either integrated into or be able to package with your VNA, that's becoming less of a concern as far as just distribution of it, but then there's also the manipulation. Many physicians want to be able to continue using their current tools, which may allow them to do more things than a DICOM viewer would do with those particular images. So I think that's probably the biggest advantage of leaving those images in their native format, is to give that physician the flexibility that they need and want to be able to manipulate those objects.
Yeah, this is John. Just to kind of expand on that, if you have physicians that are taking pictures, with their cell phones or with, 20 compliant cameras, and there's absolutely no clinical system that's going to request those images back, then it makes sense, just to wrap that JPEG image or that TIFF image into DICOM, simply because they're storing it for record. But if you ever have a clinical system that is pulling those images back, much like PACS does for related priors, and you convert it into DICOM, those images are gone to that clinical system, and you will directly impact your clinical workflow of that department.
Great. Thanks again, Nathan and John. Leslie, any questions live from the audience?
I show no audio questions at this time.
Okay. If we still have some more time, we do have a few more questions that came through. Another one came through as, which departments do you interface with, and what types of clinical content?
Hi, this is Nathan again. As was touched on, there are many different types of images that are available, and we're starting to see a wide proliferation of enterprises looking at those departments that traditionally wouldn't be part of an enterprise enterprise archiving strategy. These folks are starting to look at some of the things that we had talked about previously, as are these systems being maintained with with IT standards? What's the backup strategies? What's the redundancy? Are we getting the economies of scale of these images from these departments that that we'd like to leverage? And a lot of times the answer is no. So Terra Medica has worked with up to 24 different clinical specialties, and these range from obviously radiology, cardiology are probably the two biggest ones, contributors to the archives. Now we're starting to see a rapid proliferation into other areas. such as dermatology, where they are taking photos. We're seeing we've done integrations with oncology all across the world. That's becoming more standard. Pathology is certainly on the horizon, where people are looking at that, and integration of that into the enterprise viewing archiving strategy is coming through. Also, urology, surgery are some typical ones where we would integrate ENT, GI department. So pretty much any department that produces a clinical image, has a need for archiving, and what are you going to do with those images? And Teramedica has integrated with a wide variety of them.
And the clinical content format can cover anything from MPEGs to WAV files, JPEGs, PDFs, AV files, things of that nature.
Correct. Yeah, as we mentioned, trying to keep that into its native format is certainly an option to allow those images to be utilized in the tools that are desired.
Thanks again. I'm just scrolling through the private chat here to make sure we addressed all the questions. Looks like there's one more, and the question is, how does your life cycle management work?
Sure, I'll take that. Lifecycle management within the Teramedica archive is based upon clinical rules. A lot of times, and Jonathan had touched on this, you'll get hybrid VNAs where they do different things, where they may rely on the storage vendor to do lifecycle management based strictly on the age of the image and things like that. And while that gives you some benefit, it doesn't truly unlock the clinical nature of the images and the intelligence that can be provided by a VNA. So our lifecycle management has the ability to actually look and interrogate the clinical content to determine, based across your organization, what you'd like to do with that data. So that can range from moving it across different storage platforms to save money just based on storage costs. So again, if you have an image that you want to store on high-speed disk for 2 years because that's generally the most useful life of an image is 2 years, and then after that you want to move it off to more a little bit slower disk, but still have that retained. You can do that and save that money on that storage cost by doing that. You can also compress images more highly, so you can keep them in a uncompressed or a lossless compressed format for a desired period of time, and then move them off and compress them more highly, so you still have them available, but you're not eating up so much storage space. And then again, you can also remove those images at the end of their useful lifetime to completely save that cost. Where if you recall the slide that Jonathan had shown earlier, if you rely strictly on packs, a lot of times they don't even have the ability, so you're just going to continue to add storage indefinitely. Whereas if you can roll those off, you can plateau your storage growth. In addition, you can do other things. Many other things that can be done is you can segregate, your lifecycle management by modality or by department. Those are all available within Teramedica to do that. So you could treat mammography images differently than you would treat a CT image based off of legal retention times. You could treat pediatric studies different than a regular adult study based off of, again, whatever your legal requirements are. So lifecycle management is a very important feature within a VNA, and Teramedica provides a very robust lifecycle management engine.
Great. Thanks again, Nathan. I don't show any other questions from the audience, so what I'd like to do at this time is turn the call over to Pete Elliott at Key Information Systems for closing remarks.
Thanks, Jonathan. Appreciate good webinar, great information. I want to thank everybody participating and taking time out of everyone's schedules Just a couple of closing comments. We work with UCLA, just an example, UCLA and Children's Hospital, Hogan Cedars, and we're talking to them about all of this. I did a lot of research on this technology because we are getting involved with TerraMedica, and the relationship with TerraMedica and Key has been very significant, and we're honored to have that partnership, and we're investing in that partnership. They into us, and we're into them. But what I was really struck with the technology is it's very innovative, it's very flexible. At the end of the day, it'll protect your investment across the topologies of wherever you are and whatever you're doing in the healthcare industry. And I think that's very important for people to understand. I want to thank everybody for participating today, and I thought it was a great, great webinar. It is going to be archived, if you will, so you can listen to it again. And I thank everyone for their time. And thank you, Jonathan, as well. Take care.
Thank you.